Okay, so we're going to be talking about improving outcomes in colorectal cancer screening, starting off with a discussion of the science related to the lungs. Is that fuzzy for everyone or just me? But it's still, everybody can see it okay, even though it's got a very strange looking background. So keep us alive. All right, colorectal cancer, as I'm sure most or all of you know, is the fourth most common cancer it's actually the third most common cancer in the U.S. It's the fourth most common in the Dakotas. And it's the second most common cause of cancer death in both of those regions, in the U.S. and the Dakotas. Here is where the North Dakota stats and South Dakota. So actually fairly similar numbers in both North and South Dakota. These are the overall incidence rates, and incidence, as you can see, is higher in men. Again, these are North Dakota stats. Incidence is a little higher in men than in women, and this overall number is fairly similar to that of the U.S. general population. But this is the incidence among American Indian, Alaska Native men and women, I guess here it's American Indian men and women here in North Dakota. But you can see higher rates in men and in women. In South Dakota, again, the overall, these are still North Dakota numbers. This is mortality rates. Men are more likely to die of the disease than are women. But because there are more women than there are men in this older age group, it's still an equal opportunity killer. And again, among the American Indian population, actually American Indian women are more likely than men to die, significantly more likely. This is the general population over here. So as you can see, much, much higher likelihood of dying from the disease among American Indians. This is similar data for South Dakota. This is the overall incidence, and here it's white and American Indian all on the same slide. And as you can see, again, we have higher incidence among American Indians. We have higher mortality among the American Indian population as well. And again, we have female predominance in deaths in colorectal cancer. We do have some positive news overall, and that is if you look at colorectal cancer deaths across the U.S. over the last 3 decades, we've seen a fairly steady fall, and particularly over this last 10 years, you can see a 27% drop in deaths from colorectal cancer in the U.S. So our efforts are truly paying off, but unfortunately they're not paying off for everyone at the same level. This blue line is the white population, male and female. As you can see, it's been a very steady downward trend. It took longer. This is the black population. It took a while after that white level started falling before the black population level began falling. But it has now. But as you can see, there's a huge gap. And as a matter of fact, back in the 70s and early 80s, black men were much less likely to die of colorectal cancer than white men, and now, huge gap. These are the Alaska Native, the Asian Pacific Islander and Hispanic groups, always much lower likelihood of colorectal cancer death in those groups. But because the white population death levels are falling so dramatically, we're at a point now where another 10 years, these lines are likely to cross. So the white population is going to be less likely to die from colorectal cancer than even those lower risk groups. And in part because, as you can see, their trajectory is not nearly as steep as that of the white population. Now, while there's improvement for everyone, when you look at the American Indian and Alaska Native population, the news is not good. This is males. This is the white level just since 1990. Again, that steady fall we just talked about, but this is the trend among American Indian males. And similarly among white females and American Indian females. So we're going in the wrong direction with those groups. Clearly, a lot more work has to be done. And I think it starts with events like what we're doing today, because screening is clearly tied to the improvement that we've seen in these death rates. Now, screening is not the only thing. We certainly have improved our ability to treat colorectal cancer. As a matter of fact, I remember when the first study was published on 5-FU, that was about 25 or 26 years ago, showing that 5-fluorouracil was actually an effective agent to treat colorectal cancer. Up to that time, we didn't have any good chemotherapies for colorectal cancer. Since that time, we've had Avastin and Erbitux, a variety of other things to come into the market. So we're able to treat this disease much more effectively. And in addition, our surgical techniques have improved. We really do a much better job treating colorectal cancer when it's detected. So people are living longer and in some cases actually surviving even advanced disease. But screening leads to a very significantly improved likelihood of surviving, because when we find the disease early, colorectal cancer that's found at the localized stage, when it hasn't penetrated the colon wall, 9 out of 10 of those folks are going to be alive 5 years later. 90% 5-year survival for early detection. That's cancer. We find it, they live. On the other hand, if the disease is remote, if it spreads to other parts of the body, only 12.5% 5-year survival. So a huge difference, and we're much more likely to find disease early if we're doing screening. Now, this is what's going on right now in North Dakota. Only about 42% overall, 47% of men, 42% of women are found at that earliest, most treatable stage. So basically 6 out of 10 people who are diagnosed with the disease here are in those later stages when our treatments are not nearly as effective. So we can change this. We can change it by doing more screening. This is the same sort of data for South Dakota, and again, exactly the same. 42% are found at that local stage. As you can see, half of patients are found with distant disease, half or more. And consequently, our treatments are not going to be nearly as effective. So we're missing out on the opportunity to prevent disease because colorectal cancer screening prevents disease. We're also missing the opportunity to be able to treat people more effectively because we're diagnosing in the later stages. And as you can see here, this is data from South Dakota, the likelihood of later stage disease, the regional and the distant disease, and also unknown stage, which usually is more advanced, is more than half the cases, unfortunately. But maybe more important than our ability to find the disease early is the fact that when we screen colorectal cancer, we actually keep disease from occurring. Because if we find and remove adenomatous polyps, people don't have to get cancer. And it's estimated that more than 500,000 cases of colorectal cancer have been prevented over the last 30 years because of our screening efforts. So finding and removing polyps makes a huge difference. And that's why both the earlier detection and improved survival and the prevention component have led the American Cancer Society, the National Colorectal Cancer Roundtable, the CDC, and a plethora of other groups to band together behind this 80% by 2018 initiative. Now, how many of you all have not heard of 80% by 2018? Oh, good. Okay. 1 or 2 hands, but most folks are familiar with it. Well, this is a nationwide initiative that's been going on for just a little over 2 years now. And we've got a long way to go to get to 80%. But our reasons for doing so are spelled out pretty clearly just by this single slide. If we keep our screening rate where it currently is, what we see is a slight increase in the death rates from colorectal cancer over the next 15 years. And that's because we have more people in that older age group, more people going to die of disease. On the other hand, if we get to 80% by 2018, by the year 2020, we'll drop colorectal cancer deaths by 19% in the U.S. That's 4 years from now. And by the year 2030, 14 years from now, we will decrease deaths by 33%. Now, there's nothing else we can do in the cancer world that's going to cut deaths by a third, other than make everybody quit smoking. I don't see that happening, not in the next 5 years. But I can see getting to 80%. But it's going to take efforts like this. It's going to take work on the part of you folks and many, many others to help get us as a nation to 80%. The other thing is that we recognize that folks in community health centers, folks taking care of Native American populations, you've got a lot of barriers that the general population doesn't face. And your screening rates are consequently starting off at a significantly lower level. So getting from 35 to 80% may not be feasible, but getting from 35 to 50% over the next 4 or 5 years, that's realistic, and that's going to help move the entire nation. So it's important that everyone recognize whatever you do, whatever your contribution, it's going to help move us toward this goal. We now have more than 850 organizations that have signed on. These are organizations across the spectrum, certainly a lot of healthcare organizations, all the major GI groups and governmental groups, but we've also got a lot of folks in private industry, Walgreens, we have organizations like the AAFP, that should be up there somewhere, groups from across the entire spectrum of the organization, including a lot of just large employers who recognize the value of colorectal cancer screening both for their employees and their customers. So we have a lot of groups that are organized around helping us move toward this goal. We've also created a wealth of different tools and resources so that wherever you sit in your community or in the healthcare spectrum, we've got tools for hospitals. These are things that within a hospital system we can do to move us toward 80%. Certainly for primary care, I'm talking a lot about that. But if you are part of a community group, these are things that you can do as a community organization to help move toward 80%. So wherever you sit, there's a role for you to play in helping move us toward this goal. So where are we right now? As of 2014, data from the CDC says we are at about 67.6% nationwide. And actually, we have made significant improvement over the last decade in terms of eliminating the disparity between blacks and whites. That used to be a pretty significant gap. And in the latest CDC data, that gap is pretty much eliminated. So you've got very similar rates. Unfortunately, the Hispanic population and the American Indian population still have significantly lower screening rates than do the white and black population. And the lowest rates occur among the uninsured. These are the rates for South Dakota and for North Dakota. And I don't know, you folks from North Dakota, I think there'd be a little competition between you all. So you all gotta get on the move here. South Dakota is just below the national average. And I mean, the national average, frankly, is not great because with this, that means that basically 1 out of every 3 people who should be screened are still not up to date in screening. In North Dakota, it's almost 1 out of every 4 who should be screened are not up to date. So work to do for all of us. And this is North Dakota data, breaking it down by male, female, and also this rate for American Indians. Now, I have to say that this rate is questionable. The way that the CDC collects their data for BRFSS, it's a telephone-based survey and based on self-report, that's number one. But number two, you need to have a significant number of people who responded to that survey, and there are questions about whether this is an overestimate of the American Indian screening rate here in the state because it's based on responses from too few American Indians. This is data from federally qualified health centers and the UDS system, the Uniform Data System. Many of you all in FQHCs know that you report a variety of information to your funders, to the feds every year, including since 2012 colorectal cancer screening rates. And so within federally qualified health centers, North Dakota and South Dakota, again, are very, very similar, with essentially 1/3 of patients being up to date with screening. As I mentioned earlier, you're taking care of uninsured, you're taking care of minority groups, so you're taking care of the folks who across the country have lower screening rates. So it's not surprising that the rates are low, and your patients have a lot of barriers to getting screened. But notice, however, that look here in the Northeast, we've got states